Oh, pretty much. Many thanks for staying with us. And in case you're joining us, you're just in time for the big conversation here in regards to the issue of Ebola. And of course, we have dubbed this conversation Understanding Ebola in regards to also matters risk response and preparedness. This is a virus that has ravaged the Democratic Republic of Congo. Of course, more than a decade ago, it ravaged West Africa, more so the countries of Liberia and Guinea, together with Sierra Leone. Now, currently, Democratic Republic of Congo and also parts of Uganda are struggling to, of course, contain this particular virus, which has been deemed, very dangerous. And here to make sense and, of course, help us understand this particular virus and put to context everything that we have seen so far from, of course, like I said, over a decade ago to what is happening currently in the East African region. Two great and learned gentlemen. And of course, to my immediate right is Professor Julius Oyugi, who is a virologist at the Department of Medical Microbiology at the University of Nairobi, as well as the director, the University of Nairobi Institute of Tropical and Infectious Diseases. A very good evening to you, Prof, and welcome.
Thank you for having me.
Pretty much. Also joining us this particular evening is Mr. Peterson Wachira, who is the chairperson, KUCO, that is the Kenya Union of Clinical Officers, as well as a frontline clinician who are in the parts of the West Africa rather, during the 2014 Ebola virus situation. Of course, they went there to try and help contain the situation. Mr. Wachira, very good evening to you, and many thanks for, of course, hosting this particular show.
Thank you.
Pretty much. Before we begin this conversation, I want us to just have a look at the numbers that we're talking about, first of all, in regards to this Ebola virus and the situation in the Democratic Republic of Congo. And as we speak today, the Democratic Republic of Congo has recorded at least 1,307 cases with 377 deaths and, of course, 180 recoveries. 1,307 cases, 180 recoveries, and 377 deaths. Let's have a look at the situation in Uganda now. And Uganda has recorded 20 confirmed cases. We have 15 recoveries, and 2 people have lost their lives to the Ebola virus. This, of course, is the Bundibujo strain, and we'll be talking to the 2 gentlemen in regards to those particular strains. Now, generally, we have 1,328 cases across the 2 nations. Recoveries stand at 195, and fatalities stand at 379. Now, here in the country, even as the conversation in regards to matters, isolation facilities, and all take center stage, we are yet to record any case, but we have around 23 counties which have been deemed of high risk. Now, let's begin this conversation. Let me begin with you, Prof. First of all, we talk about the Bundibujo strain, which is currently the one ravaging DRC and parts of Uganda. In 2014, more than a decade ago, I think we had the Zaire strain, if I'm not wrong.
Yes, in West Africa.
Yes, in West Africa. Talk to us about these 2 different strains, and how do we determine this is the Bundibujo strain, this is a different strain?
So both of them are Ebola viruses, but they have gone through what is called mutations. They have changed a little bit, so they look different. So we have Ebola Zaire and Ebola Bundibujo. The 2 of them, the one has been causing a lot of outbreaks in DRC and West Africa, is the Ebola Zaire. Bundibujo is actually a more recent virus. The first time it was discovered was in 2007 in Uganda, in a district called Bundibujo. That's where it actually got the name. And then the next time was in 2012 in DRC. And this is the third time that it is appearing. So Bundibujo is more of a rare Ebola virus compared to Ebola Zaire. Mm-hmm. Yes.
Pretty much. Just to, also make sense. Mr. Wachira, you were part of the team that went to West Africa then.
Yes.
You witnessed the scenes there, and we did run a story here in regards to the situation, what happened there. Over 28,000 cases were recorded in 2014 in the West African part of the continent, and of course, like I said, it was more predominant in 3 countries. But more concerning is that we lost over 11,000 citizens. Of the 11,000, there's been concern because the story that we did run earlier on is over 3,000 children who died. Having been at the forefront of that particular virus, how crucial is adequate preparation? We've had the conversation in regards to isolation centers, and generally how we are prepared as a nation. From where we sit, having been there, are we adequately prepared in case we have such a situation?
Thank you, Ian. And as you have said that I have prior experience, and we are still retained by the Africa CDC as surge capacity. We are called AVOC, Africa Volunteer Health Corps, together with, of course, all my comrades who we were with from different countries. And in terms of preparedness, I would say that we are taking the right steps. We are not there yet. There are things that could be done better. And I think we have to understand that there are different things you do at different times during an outbreak. Where we are currently, we are at the preparation level. And at the level of the preparation, there are several things that you need in place. And one of the failures that led to more than 11,000 people dying in the 3 countries was actually lack of preparedness because, of course, they were caught pants down. It's not something that they were expecting. And I can tell you that if they were prepared, we would have probably at most lost not more than 4,000 people. You can see that because of the level of preparedness that we are having, and I think Uganda would be a very good example. You can see if we are to get the case fatality in Uganda, 2 out of 20, that's around 10%. But you can, then if you compare that with the DRC, because of course of the levels of preparedness, the capacity of the health system, we are having to a tune of around 25 people or 26 people out of 100 who are infected. So objectively looking at it, I would say that there are things that we need to do better. And a very good example is Laikipia, for example. You saw what happened. There are people who have been demonstrating. There are people who have actually died from the demonstrations. And that was actually lack of preparedness on the side of the government, because in risk communication and community engagement, which is one of the pillars you engage when you are preparing, because when you are preparing, you engage risk communication and community engagement. There is the issue of training healthcare workers and, of course, capacitating your laboratory network to be able to handle that. So if you look at the case of Laikipia, there is something that we call social listening. Social listening is you want to listen to the populace and you understand their fears. And when you understand their fears, then you are supposed to respond by sending experts in risk communication and community engagement so that they can replace that fear with facts, because fear brings stigma. These people are acting out of fear and the stigma that would come with an Ebola case. And now that was even spiraling out towards a stigma against a quarantine facility. And what the government should have done is simply not to send the police, because people are expressing fear and then you're sending police to batter them. They should have sent experts in risk communication and community engagement to go down to the people, to sit with them and dissipate this fear by giving them facts. Yes.
Okay, pretty much. Coming back to you, Prof. I mean, this is an outbreak that we've witnessed before. Like I said, more than a decade since the 2014, outbreak in West Africa. Why is it so difficult to contain this particular virus, having, dealt with it before? What is the problem in handling this particular, virus?
So if you look at the outbreaks due to Ebola virus, the first one that took place was in 1976 in DRC. And there has been several, about 17 outbreaks of Ebola in DRC since then. The problem, if you look at these viruses, the way they actually emerge in a population, people who are infected with Ebola, first of all, they present with symptoms similar to malaria, typhoid, and other diseases. So if they present with the health facilities, most of the time the doctors and healthcare workers would think that they have malaria. So those initial symptoms are very difficult to identify. So what happens during the early stages of the epidemic, if you don't identify people early, the disease actually spread exponentially. And by the time you know that Ebola is there, quite a number of people have been infected. So that is one thing. They come disguised as other diseases. The second thing, if you look at where these outbreaks actually occur, these are areas where there are conflicts. Like DRC, if you look at the outbreaks, they are in areas where the minings are, the rebels are in these places. So the health system infrastructure is very weak. They don't have very well trained healthcare workers. They don't have laboratory capacity. So identifying Ebola and stopping it becomes a challenge. So these are some of the challenges why over the years it's been very difficult to manage Ebola. And finally, unlike other diseases, Ebola diseases, virus diseases actually don't occur regularly. They occur once and then they disappear. And we don't know when the next outbreak is coming. So even preparing for the next outbreak becomes difficult because you don't know when the next outbreak is going to occur and which Ebola virus is going to take place. Mm-hmm. As we speak now, we're talking about Ebola Bundibugyo virus. The last outbreak was Ebola Sudan in Uganda. Yeah? Mm-hmm. So, and these viruses are different. The way you prepare for them is different between one Ebola virus and another.
If I'm to ask, what is Kenya's risk level as of today, Prof?
The risk level is considered high, particularly because we are very close to the epicenter of Ebola outbreak. Yeah, there's a lot of traveling between the two countries where the Ebola virus is now. There's a lot of traveling between Uganda and Kenya, and there's a lot of traveling between people from DRC to Kenya. Uganda is even riskier because of our borders are porous, so people can actually move between the two countries without necessarily, identifying those who are carrying Ebola. So we are at a considered high risk because of proximity to the hotspots of Ebola outbreak.
Okay, Mr. Wachira, you talked about the stigmatization, the fear, and even about in regards to the facility in Laikipia. But having been at the forefront,
yes,
what breaks the response the most? Is it adequate staff? Is it trust? What breaks the response on the ground the most?
Thank you. And maybe before I respond to that, I can also take on the question you asked, Prof.
Okay.
There is a major transport corridor linking Congo to the other countries in East Africa, and of course through Kenya. And I think last week, but one, we had over 70 trucks that were coming from the epicenter. That is Ituri province and northern South Kivu. Now, these trucks will leave there, come all the way through Uganda, through Kenya, some terminate in Mombasa, some will even go to other areas like Tanzania. So the incubation period is between 2 days and 21 days. And this simply means the period when you're infected but you do not show symptoms. And this person at that point, they do not understand whether they have the disease. They don't know. And yourself, you can't know because they don't have any symptoms. So it is possible for this truck driver to come all the way and reach probably Tanzania, and they'll only develop symptoms when they are going back. Now, looking at the behaviors along this transport corridor, you have areas where they mingle with Kenyans. If you look at Salga, Mlolongo, Emali, and some other areas, they come, they sleep there. Sometimes they also interact with some key populations, like the sex workers. And so that is why the risk is actually high. But other than that, I don't know, how many Congolese young men do you know who operate kinyozis and what have you? And some even in the mining sectors in Migori and elsewhere, and they're undocumented. You won't know when they came into the country. And that's what increases the risk. Now, coming to your question about the stigma surrounding it, and I think I'm one of the persons who came out when, of course, there was that discussion about Laikipia, And I came out and people thought I was supporting government, but actually I was not supporting government. My worry was, it was a deja vu moment for me, because in Sierra Leone, where I went and where I was a team leader, one of the reasons as to why the outbreak was able to spiral out very fast was actually the same, that there was political undertones, that this Ebola was associated with government trying to eliminate opposition and what have you. And people believed that facilities were there to eliminate those who do not die from Ebola in the community when they go to the facilities. And so at the start of that outbreak, quarantines were actually demonized. They were seen as unsafe places for the community, whereas actually quarantine facilities, isolation facilities are very safe places for the community. They are expected to make the community safe. So it starts from the risk communication and community engagement, because this pillar, or this pillar in the response or in the preparedness, is about informing the populace so that they understand what is this disease. How do we recognize that we have this disease? If we think we have it, how do we send an alert to the authorities? And then how do you prevent it? How can you get treated? Are you going to die from it? Once the community understands and they have the facts, that is the only way you can get rid of stigma, because stigma comes from fear. And fear comes from lack of knowledge. So you give knowledge, you give the facts, then you demystify the fears, and then the stigma will not be there. So it is also ensuring that you have healthcare workers who are well trained, and I think this is one thing where we are doing at a very slow pace, because for you to get the first diagnosis, it will most definitely come from a hospital, whether a dispensary, a health center. But that clinician, that nurse, that doctor who is sitting at the consultation clinic must be well trained so that they can be able to pick it. If they do not pick it, they actually become one of the focal points of transmission. And if you are to look at the 2013 to 2016 outbreak, you'll see that out of the 518 health workers who we lost then, about 306 were either clinical officers or equivalent, or laboratory officers, the people who come into contact with either specimen or that patient at the first place. So training, risk communication, and of course ensuring you have the laboratory capacity. Of course, now when we get a case in the country, then you have to have the case management, where now we talk about the isolation and the quarantine facilities. And in risk communication, the most important thing is that you go to the communities and talk to them about something that we call case definition. Okay. Case definition simply means, how do I suspect that somebody has this disease, so that then I can be able to send an alert?
Pretty much. Prof, I'm no health expert. I'm merely a journalist. And in the course of doing my research, I came across a concern, and of course you'll correct me if I'm wrong. They said, like, the Zaire strain, this Bundibujo strain has no licensed vaccine specifically for it. If that is the case, how then does this affect the response in tackling the virus?
Yes, you're right. The current virus that is causing the outbreak, the Bundibujo, does not have any licensed vaccine, although the sister virus, Ebola Zaire, has a vaccine. Now, in the case where there is no vaccine, the public health response is different. If there was a vaccine, like when there was an outbreak of Ebola Zaire, they use what is called fencing vaccination, where you identify the people who have been in contact with the case, vaccinate them, and then stop the spread of the disease. Mm-hmm. In the absence of the vaccine, now you have to use a different approach. The first one is rapid identification of those who are infected with Ebola. That requires proper laboratory system that can support detection. And once someone is confirmed to be having Ebola, then that person has to be isolated from the community. So there's the isolation component. The third thing is that there must be what is called infection control protocols within the hospital environments, because as my colleague has said, the people who get infected most are actually the healthcare workers. So they need to be trained. There must be very proper infection prevention control mechanism within the hospital. Those are very important key steps in handling Ebola in the absence of the vaccine. What this means is that the cost is actually much higher in the absence of the vaccine, because you are dealing with several things. As the epidemic progresses, you must have very strong laboratory infrastructure. You must have the stocks of tests to test these people. You must have isolation facilities, which are very critical. You must have very well-trained healthcare workers. All these are a little bit more expensive than if you had vaccines in place.
Pretty much. You've highlighted one important thing, laboratory infrastructure.
Yeah.
As of today, what can you say about our laboratory capacity as a country?
I think we are fairly, we are not fully there, but we have done very well in terms of having laboratory infrastructure. Mm-hmm. I actually belong to the Ministry of Health technical experts for the laboratory strengthening system. Mm-hmm. We have laboratories actually placed in strategic locations, like in Busia, for example, which is actually at the border between Kenya and Uganda. We have labs there where if someone is actually suspected to be having Ebola, they would be taken sample and tested, and if they are positive, they will be actually isolated from there. They will not move very far. We also have other centers in Kenya where Ebola testing is being done. And so we are not 100% there, but we are at a safer place as a country.
Finally, before I talk to Mr. Wachira, we talk about surveillance and early diagnosis as very crucial to tackling this Ebola virus. Why is that so? Why are these two elements very important? To you, Prof.
To myself?
Yes.
Okay, surveillance and early detection.
Yes.
Now, surveillance in a layman's language is looking for those people in the population who are suspected to be having Ebola infection. The word is suspecting, right? Mm-hmm. But because the symptoms that these people present with are common to many diseases, you really need to do a laboratory test to confirm if they are infected. The laboratory test should be rapid. Rapid means it should be fast enough to produce results and say, Oyugi is infected, please isolate him. So looking for the people actively in the population through community, what my colleague was talking about, in areas like, say, the border between Kenya and Uganda, community should be, educated about case definition of Ebola. And if somebody is suspected, that's part of surveillance. You bring that person to the health facility and do the testing. Some tests take longer to get the results. Yeah? Mm-hmm. In this case of Ebola outbreak, you don't need tests that will take like days to get the results, because number one, if this person is infected and the result does not come out immediately, he may not actually be isolated, and that may actually cause risk to the community in this person passing the Ebola virus to other people. So there must be very rapid identification of this individual through rapid diagnosis.
Okay, pretty much.
Yeah.
Mr. Wachira, I engaged the PS for Medical Services,
yes,
Dr. Oma Oluga, who, of course, I believe was one of your colleagues and who joined you in West Africa at that point in time, if I'm not wrong. He talked about preparation and the training of health practitioners here in the country. Yeah. What is the status as KUKO? How prepared health practitioners here in the country in terms of nurses? Are they adequately equipped and trained to counter this particular virus in case of an emergency?
I would say probably we are doing less than 50%, and I highlighted and said that probably that's where we are not doing very well. There has been some virtue trainings, which to us and from our knowledge, they're not very successful, and especially when you're dealing with a disease of the magnitude of Ebola, which of course even the health workers themselves have a little bit of fear. So our expectation is that we should be able to go down to all health workers, and especially within that transport corridor, the 23 counties, so that we can take them through a comprehensive training. Myself, I've gone through a comprehensive training just like 2 weeks ago, and that gives you a lot of confidence. You know, some of us who have been there, done that, may have some bit of confidence because of experience, but there are many other clinical officers, nurses, doctors out there who have not been able to do this. And for them to be bold enough and to have that courage to be able to even work when they know that there is that risk, and especially when the first case lands, then it needs a lot of reassurance, a lot of training. So what is the importance of training? And why do we insist on training health workers? It is, as I said, if today Ebola was to be diagnosed, or we were to have the initial case in the country, it means that there is a clinician who sat somewhere in an outpatient, or there is a nurse from a dispensary who saw this patient, and from a high index of suspicion, because as Prof has said, this is a disease that mostly will present like any other. In fact, if a patient presents to you in Busia and tells you, I'm having a headache, some bit of fever, I don't feel like eating, and some muscle pains, the first thing you're going to think about is not about Ebola. It's about malaria, probably. That is the most predominant disease there. So they must be trained and equipped enough so that they have a high index of suspicion, and once they do that, then they can be able to alert, and the tests can be done, because it's only the test that is going to differentiate. And it's through that then now we introduce the case definition, so that it is not everybody who has these symptoms that you suspect to have Ebola, and especially in a country like ours where we do not yet have local cases. So the case definition is, this person has these symptoms. And with the symptoms, then that must be accompanied by either a history of being in an area where there is local spread like Uganda and Congo, or they are belonging to a category that we consider high risk, who may interact with those people without their knowledge, like sexual workers, a person who deals with especially wild animals, they a ranger, cavers who may come into contact with the bats, which are the natural reservoirs. And that is the person we usually call a suspect. And then there is another category we call a probable case, and this is basically a suspect who can confirm to you that I was actually in contact with somebody who had been diagnosed to have, or confirmed to have Ebola. So it is using now these case definitions, okay, and of course having that confidence that we will be able to get that case. Now, the problem is, if we actually have somebody who has Ebola and comes to that facility and they are not picked, because what is going to happen, they are going back home, they are going to infect their kids. By the time you realize that you're having a spread, then of course the outbreak will have started.
You've talked about, the training and all, but in terms of the health workers themselves, yes, do they have guarantees on, things like, PPEs, insurance and all?
For the PPEs currently, from the inspection that we have done and from our side, after COVID-19, we relaxed on very many things, and I think that applies to all Kenyans. You remember during COVID-19, everybody had a sanitizer. Probably we would be having a sanitizer somewhere on the table.
We do have one over there.
You do have one?
Yes, we do have one.
At the entry of all hospitals, you had some hand-washing places. We were inspecting, and some of them no longer have those. So we do not have enough provisions in terms of PPEs. That is something that we are lacking currently, and we have a very bad tradition that we usually rush at the last minute, and these are things that we should be able to have. And I remember there were some manufacturers who would actually do this locally, and this is the time that we can actually promote that and ensure we have enough PPEs. So we are not doing very well in training. Mm-hmm. We are also not doing very well in the side of supplies. We may not know the full breadth of that because probably we haven't had the first case, we haven't been able to train, because you also need a lot of PPEs when you're training. For the case of Ebola, and especially for health workers, until you're trained and you wear that PPE, for us we say you have not trained and there is nothing you can do because it has its own dynamics. Sometimes the temperatures inside that PPE will go up to even 40 or 41. Some people even get heat strokes. Some people get very anxious and collapse from that.
Okay.
Yeah.
Pretty
so
much.
That's where we are.
Fair enough. Prof,
Yes.
when you listen to Mr. Wachira here talk about how prepared we are, and even in terms of training and all, saying that we are less than 50%, the issue of virtual training, which is not considered good enough. What does that say, and what do we need to do?
I think part of the preparedness dealing with an outbreak of a disease like Ebola require resources. Yeah, they come as emergencies. They come and all of a sudden you are required to have this PPE in most facilities where you consider there's a risk of having an Ebola patient. Yeah, but in addition to all these PPEs, there's also the need for training. As he says, healthcare workers, if they're not well trained, then there's fear of handling the Ebola patient. And we have seen cases even in the US where a healthcare worker gets infected with Ebola virus as a result of handling Ebola patients. So there's need to have thorough training. There should be drills, what is called drills. After training, there should be drills in facilities so that people who have been trained can be assessed to see if they can actually implement what they have been trained. And that should be going on right now, because as we are experiencing the number of cases of Ebola increasing, we should not actually just do the training and leave it there. We need to continuously also have drills in most of our health facilities. Ideally, most health facilities should be having these PPEs. But I think as a country, we don't have enough resources to put these PPEs in all hospitals. Yeah? We would put them on a need basis. Like right now, because of Ebola, I'm sure most of the health facilities along the border between Uganda and Kenya are having some level of these PPEs in these facilities. Yeah, but we should be having them to protect the healthcare workers from being infected by Ebola.
Pretty much. Let's talk about mothers and children. Like I alluded to earlier on, of the 11,000, over 11,000 for that matter, deaths that were recorded during the 2014 strain in West Africa, at least 3,000 were children. Now, looking at this number, it is heartbreaking. I was watching a documentary on what happened, and there was a mother who was struggling, no shelter, no food, with around 6 children, and eventually she lost 3 of them. Talk to us about children. How big of a risk are children facing in case we face such outbreaks?
You see, the way Ebola is acquired is through contact with a body fluid of someone who is infected, or it could be contact with a cloth that has been used by someone who is infected. And as adults, if you have proper education at community level, we'll be careful enough not to interact with either body fluids or linens that have been used by patients who have died from Ebola. Children may not actually cannot protect themselves at the level of adults. But when you talk about women, for example, my colleague was talking about transmission of Ebola. Ebola is also transmitted through sexual transmission. And if you look at in West Africa, for example, most people who recovered from Ebola, particularly men, there were myths that once you recover, you may not actually be, having Ebola virus in your body. But we know that men can actually transmit Ebola through semen, through sperms, for up to 1 year after they have recovered from from Ebola. So they can transmit this to their wives. So this was going on because of, a lack of understanding about who should be transmitting the Ebola. It's not that person who is having the symptoms, but the people who recover from Ebola also transmit Ebola to other patients, other partners as well.
Finally, before...
and maybe in addition to that, as you rightly said, Ebola does not have some definitive drugs to manage, does not also have a vaccine. And your recovery is dependent on your level of immunity. And we know that the level of immunity of course, young children is a bit lower. So that means that in that space of the children, then the case fatality rate may actually be higher than the adults.
Okay, I was to ask Prof before I come back to Mr. Wachira. You talked about, farmers, you talked about birds, and again, coincidentally, I was in the 2014 outbreak, there was that concern around, birds and all. What is Kenya's surveillance on, these issues, be it birds, be it, bushmeat? What is our surveillance per se?
In West Africa, unlike Kenya, bushmeat is actually considered a delicacy. Bushmeat. So people go to the forest, they catch monkeys to eat, and in the process of slaughtering these monkeys, there is contact between blood from this, and we call them non-human primates, to humans, and that could be a potential route of transmission of Ebola. In Kenya, we actually don't practice bushmeat as much. That's number one. So Ebola can be found in non-human primates, like the monkeys and chimpanzees. But what is called the natural host, where Ebola virus actually lives without causing disease, are bats. And there's a particular species of bats called fruit bats. And these bats are actually found in the rainforest in Central Africa. And this is why, if you look at most outbreaks of Ebola, they've actually been occurring in Central Africa, in DRC. So if you get into contact with those bats, then you are likely to get infected. Getting back to you, what is Kenya doing about surveillance of Ebola virus in these bats or animals? At the University of Nairobi, where I work, we have a research program that is actually looking for bats across the country to find out if we can find Ebola virus. We've been doing this research for the last 3 years, and we have not found any trace of Ebola. So we have, at the level of research, we actually have programs that are actually looking for Ebola virus, including a sister virus of Ebola called Marburg, which has actually been identified in Kenya in early 80s. So from the research side of things, we are actually looking for Ebola in places where we think it should be.
Pretty much. Mr. Wachira, we talk about preparedness. Of course, we do know health is a devolved function.
Yeah.
I don't know, as a union and even as stakeholders in the health sector are privy to, the state of preparedness also in counties, at the county level. And maybe again, even as you answer that, how do you talk about preparedness in the context of, being involved in terms of the preparedness as unions, be it KUKO, be it, the other health unions? How involved have you been in terms of, from the Ministry of Health?
Yeah. So the counties are not prepared. Most of them, of course, they're asking the national government. I don't know whether the role of disaster response is actually devolved or it's with the national government. But as a union, we have tried to carry out some audit of some kind because, of course, our members are at the front line and they are the ones who are most likely to be infected first. And what we have found is that in many of the counties, the preparedness is very low. In fact, the situation is like the counties are waiting for the first case so that they can start preparing. There are not trainings that are going on under the counties, except for the ones being conducted by the National Public Health Institute, which is a national parastatal. The provisions are not there. Even the designation of quarantine and holding, when a patient would be suspected, they are supposed to be held somewhere as you alert those in the emergency operation center to come for the patient. And then it would be ideal that, especially when you're having local cases, you have your own quarantine facility where you can put this person before you diagnose, and then from there you can transfer them to the isolation center. And you know, especially for a quarantine facility requires that you must be able to separate these people very well so that they also do not interact, so that if you have one with Ebola, then they do not infect the other. So the counties are not prepared, and it is very unfortunate that it seems as if we are waiting for the first case to be diagnosed. And I think it's good that we demystify what has been going around, people saying, you know, it has never been here since 1976, and now it is here. I think France just recorded their first case the other day, and it was never there since 1976. But the fact is, it is even possible for Uganda to be declared free of Ebola, and later you get a case in Kenya. As Prof has said, we have many trackers who may suffer from Ebola. They may recover, and they may be carrying this in the privileged sites like semen, like testes, where now, of course, it will be in semen. And we know the interaction between sexual workers and these trackers in Kenya. And so this can actually even happen several months after it is declared, after Congo and Uganda are declared to be Ebola free. And then you get a case coming on from Kenya when all of us have relaxed. And the problem with that is that by the time you are realizing that you're having Ebola, we will probably have lost the medics who are dealing with that patient. And probably now, the community, it will already be spreading within that community.
Especially it being, you know, campaign season, because we're heading into the 2027
yes.
election.
Yes.
Well, let me come back to you, Prof. You talked about funding and there are concerns about, you know, whether funding is enough, there are funding shortages and you know, all that, which could delay the evaluation of experimental treatment. The question then would be, how important is it to test new drugs during an active outbreak?
Yeah, that's a very important question. You're talking about either a new drug or a vaccine. In particular, we're talking about a virus like Ebola that is circulating right now. The way drugs are licensed is that you must do studies in human beings. And it's done in stages. Yeah, there's stage 1, called clinical trial phase 1, stage 2, stage 3. Stage 3 is where you are looking for people who are at high risk of getting that particular disease. In a case like Ebola Bundibugyo, for example, if we have a vaccine now, it would be, or a drug, for example, it would be good to use it during this time when people are actually sick to see if this drug is effective or efficacious and is safe in these people. Remember, as I told you, Ebola Bundibugyo, this is the third time it's appearing. So it will come, if it disappears, it will now take several years for it to come back. Now, if we develop a drug in between, it will be not possible to know whether this drug is effective in treating these patients or not. So it is very important that those drugs are tested now. The problem you're talking about is that for you to test the drug, you also need resources. These resources require, you know, training of the healthcare workers who are going to administer this drug. Remember, these are very dangerous, you know, virus. Number 2, if you delay providing funding, there are also regulatory issues. Each country must approve the use of such drugs in the population. That also takes time. So if you delay providing funds, you are delaying the approval, you know, time for that drug to be administered, and you're also delaying the rollout of that drug to be tested in this particular case. And if that delays, by the time it is approved, Ebola Bundibugyo would have disappeared, and there will be no people to test this drug in. So that's why it is very important to test it during this time.
Okay, fair enough. Earlier on you talked about children, and you know, there are those who survived, of course, and there are those who will survive in case there is any outbreak. But are there any post-Ebola complications that, you know, come with it?
Yeah, there are what they call post-Ebola, syndrome, which lasts with people for quite a few years, and they vary from individual to individual. And this has been, documented in outbreaks of Ebola both in the DRC and in West Africa. And so Ebola virus, despite the fact that some people will now recover after years, the Ebola will not be in their body, but they will still be having certain symptoms associated with Ebola for quite a number of years thereafter. So that is something that we are seeing, just like we saw that in COVID-19 as well. So the virus will not be in your body, but you still have certain symptoms that stay with you for quite a long time.
Mr. Wachira, you're on the front line again. What is the most difficult thing in terms of dealing with children who are infected with this particular virus compared to adults, for example?
Yeah, thank you. And maybe just on the post-Ebola syndrome, I think just to add to that, the issue of painful eyes was recorded, what we call uveitis. There is the chronic fatigue and just pain within muscles that probably cannot be associated with any other thing other than the Ebola. So the complexities with children, as I said, is that, of course, because of the immunity, Ebola is pretty much, your recovery is pretty much about how strong is your immunity. And of course, for the young children, now the risk is, the caregivers are the mothers, and the children can either be infected during birth, during breastfeeding, and of course, when the mother is taking care of the child, if the mother is infected. So because they are dependent on a caregiver, then of course they are most at risk. And one mother will be dealing with probably several children. And so that is why you'll find in a family there are several children who are infected, and the numbers might be actually higher than any other age group. And of course then when you come and isolate them, and probably at some point you may actually find that their mothers are not there, they may have passed, or for one or the other reason you're isolating them alone, then there is also the issue of the psychological recovery and the psychological stress that also lowers the immunity further, because these are people who are dependent on a caregiver whom then they have to be familiar to them. So I think those are a bit of the complexities that we are able to see.
Fair enough. We're running out of time, and I'll give you a couple of minutes each to, of course, give us your final submissions. But even as you do that, one would wonder, what lessons does the global health community take from this particular recent outbreak in terms of, ensuring that we're even better prepared in case we have such occurrences in the future? Beginning with you, Prof, maybe.
Yeah, so if you look at the current outbreak of Ebola, I was looking at how the first cases were identified, and it looks like actually this Ebola started circulating much earlier, and it did that for weeks before it was discovered that Ebola was actually circulating in this part of the world. And I think normally people would wait for World Health Organization to declare that this is a problem. And once WHO has declared that, then now the country is able to get resources, to deal with the virus. So I think this idea of coming late in the outbreak of a disease like Ebola, we should actually think of a way by which we are able to identify the pandemic much early and stop it. Yeah? And one thing that should be done is to have continuous surveillance. We know that DRC is an epicenter of Ebola, so there should be constant surveillance of Ebola in this region. Now we are also seeing Uganda also becoming a hotspot for Ebola. If you look at the history of outbreak of Ebola, 15 years ago, Uganda had not recorded any Ebola outbreak. But within the last 10 years or so, we have been seeing frequent outbreaks of Ebola in Uganda. It started in DRC, I went to West Africa, Uganda, and I think in the next 5 years or 10 years, Kenya will also be in the same hotspot. So we need to focus on early detection and surveillance to prevent outbreak of these diseases in the future.
Okay, maybe even before Mr. Wachira comes in, from an expert point of view, in terms of when you talk about this funding and shortages and all, and ensuring that we're well prepared, what would be your advice maybe to the stakeholders in the health sector from the government side of it?
So the government, they know what should be done during an outbreak of Ebola. So like the health facilities that we have, we should actually now start thinking of, we should have health facilities with isolation, proper isolation centers. We don't actually make them during outbreak. We should think of having the PPE in our health facilities so that we don't actually wait until there's an outbreak. It's when we are looking for funds to do that. If we plan early, it would be very easy to deal with outbreak rather than waiting until there's an outbreak and then now we start looking for funds. Maybe at that time we don't have enough funds to deal with this disease.
Okay, pretty much. Thank you very much. Mr. Wachira, your party chair.
Yeah, thank you. And I think mine would be in two different aspects. One to Kenyans in general. And what I would like to tell them is that we are at risk of getting Ebola, and we can actually get a case of Ebola. But the good thing is that we have the capacity. There is a difference between the preparedness and the capacity. We have the capacity in terms of we have a pool of health workers who have experience and who are trained. And of course, having the experience responding to also COVID-19. And also inform them that a quarantine facility or an isolation facility is actually good for the community. It is there for your safety as the community to separate those who are sick and those who are not sick so that the infection does not continue spreading. And to the government, one thing I would say is that let us utilize the experts we have, especially in risk communication and community engagement, so that where we have Kenyans rising up against these matters related to Ebola because of lack of knowledge or facts, then we send the right people. Because when we send the wrong people in terms of police, instead of demystifying the fear, we actually propagate it more.
Okay.
The other thing is that we really need to train our health workers and do it fast enough so that we can be able to identify in case we have a case. And lastly, we must provide funding to ensure that we are doing proper preparedness. I saw the other day the president, because there is a threat of El Nino, I heard the president say that we have set aside 2 billion. I have not heard a similar thing, that we have set aside this kind of money to, of course, prepare for Ebola. And we know the consequences that would be there if we were to have an Ebola outbreak, even one case. Tourism is going to dip. And of course, many, many more billions will be lost in that. Thank you.
Pretty much. Of course, that was the chairperson of the Kenya Union of Clinical Officers, Mr. Peterson Wachira, alongside Professor Julius Oyugi, who is a virologist at the Department of Medical Microbiology at the University of Nairobi, and also the director, University of Nairobi Institute of Tropical and Infectious Diseases. Thank you very much, gentlemen, for making time to be with us this evening.
Thank you very much.
And of course, to our viewers, many thanks for staying with us up to this particular moment in time. For now, we wrap up affairs here on KTN Prime. Do have yourself a wonderful night. If you're not sleeping, for viewers, of course, even in different parts of the globe, do enjoy the rest of our programming. Until next time, have a good night, and like always, God bless.